Hello, my name is Amy Dwyer. I'm an Associate Professor of Medicine at the University of Louisville and the Director of Interventional Nephrology. Today I'm going to be presenting 3 cases of stent migration. I will explain why stents migrate and how you can prevent this from happening. If you think of natural venous anatomy, veins get larger as they go to the heart. In addition, in a vascular access, the blood flow is flowing in the same direction as the veins are increasing in diameter. If an undersized stent is placed, it will migrate forward because there was nothing for it to hold on to keep it in its proper place. This first case found to have high venous pressures during hemodialysis, and the surgeon was consulted to evaluate and perform the angiogram. A 90% stenosis was found at the venous anastomosis from the graft to the axillary vein. It was angioplastied using a 6 mm by 2 cm balloon. The post-angioplasty angiogram that has a residual stenosis greater than 50%. The decision was made to place a 6 mm by 5 cm bare metal stent at the venous anastomosis. The stent was successfully deployed at the venous anastomosis. However, within seconds it began to migrate. As you can see on an angiogram of the pulmonary artery, you can see the stent lodged at the bifurcation of the right pulmonary artery. The stent was later retrieved by the University vascular surgeon. He accessed the patient's femoral vein, used a snare to retrieve the migrated stent, and pulled it out through a venotomy that he made in the femoral vein. The second case is a patient of mine I performed an angiogram on for high venous pressures. During the second angiogram, you can see that he has a significant stenosis at mid-fistula and a significant stenosis at the distal end of his existing stent. In addition, there is a very severe 90% stenosis at the proximal end of the existing stent. These lesions were treated with a 10 mm by 4 cm non-compliant conquest angioplasty balloon. As you can see, the post-angioplasty angiogram reveals a significant greater than 50% residual stenosis at the proximal end of the stent. The decision was made to angioplasty the proximal end of the stent with a 12 mm by 4 cm balloon. After the 12 mm by 4 cm balloon, you can see that there is still recurrent stenosis. I chose a Viabon stent graft. Immediately, the stent migrated proximally into the axillary vein. What I did was I advanced the 12 mm by 4 cm angioplasty balloon inside the migrated stent, inflated the balloon, and attempted to drag it back distally, at which time I was able to deploy a second Viabon stent graft to cover the distance between the two. This is the final angiogram, and it shows a good result. This third case is also a patient of mine who presented to the Access Center with a clotted axillary artery to axillary vein loop graft. This is the initial angiogram of the pullback demonstrating the significant stenosis at the venous anastomosis at the proximal end of his existing stent. I first performed a percutaneous thrombectomy and then an angioplasty of the end stent stenosis with an 8 mm by 4 cm conquest angioplasty balloon. As you can see, post-angioplasty, there is recurrent elastic stenosis at the proximal end of his existing stent. I chose a 9 mm by 10 cm heparin-coated Viabon stent graft. As you can see, the stent begins to migrate proximally before it's fully deployed. I pulled back on the stent catheter to try to reposition the stent. However, the stent dislodged from the catheter and migrated proximally. I used my angioplasty balloon, inflated inside the migrated stent, and attempted to drag the stent back distally. Initially, this maneuver was successful and I was able to drag the stent back distally into position. However, it immediately migrated all the way to the inferior vena cava. On this angiogram, what I first want to stress is that my wire is in the inferior vena cava. I place my wire very far into the inferior vena cava. In case a stent migrates, this protects the heart. And if the stent migrates this far forward, it will take a ride on the wire and not go into the heart and into the pulmonary artery. I used the same maneuver by inflating my balloon inside the migrated stent and dragged it back distally. It took several attempts, but I was not able to get the stent all the way back into proper position. Because the stent continued to migrate proximally after I deflated the balloon, a barrier was required. I accessed the patient's femoral vein, advanced a guide wire to the brachiocephalic vein, and then advanced a 14 millimeter by 4 centimeter Atlas balloon and inflated it in the patient's brachiocephalic vein and SVC. This balloon acted as a barrier to prevent the stent from migrating further down into the inferior vena cava. With the barrier balloon in place protecting the patient's inferior vena cava, I was able to deploy a second stent, bridging the migrated stent and the existing stent. This locked the migrated stent in place. This is the final angiogram showing procedure success. Why do appropriately sized stents still migrate in hemodialysis vascular access? It's recommended that stents in vascular access are oversized at least 2 millimeters from the nearest normal sized vein distally. In the last two cases, I appropriately increased the size of the stents by 2 millimeters and both stents still migrated proximally. In hemodialysis access, the blood flow in the central venous system can get up to 2.5 liters per minute. Stents migrate because there is an anatomy issue with veins getting larger and a flow issue with the tremendous flow in a vascular access. Post-angioplasty, in this illustration, there is a greater than 30% residual stenosis, which meets criteria for stent placement. I believe that this stent device that I developed can solve the problem of stent migration in hemodialysis vascular access. The device includes a stent catheter on which there are two retention elements proximally and distally to the stent, and there is a covered stent between the two retention elements. It is important to inflate the distal retention element first to temporarily stop the blood flow in the vascular access and prevent the stent from migrating proximally. The proximal retention element is inflated second, preventing stent migration forward. The third step is to deploy the stent while the retention elements are both inflated. Once the stent is fully deployed, the retention elements are deflated and the stent catheter is removed. As you can see, stent migration can occur in dialysis vascular access. I believe that this new device can prevent stent migration from happening. If you have any questions, please feel free to contact me.